Deep inside the skull, the petrous portion of the temporal bone contains the most anatomically dense and dangerous real estate in the human body. Visualizing this three-dimensional web intact is nearly impossible, making the region notoriously difficult for medical students to master. Hidden deep within the surrounding solid bone is a specific surgical hazard zone, the air-filled middle ear space, known as the tympanic cavity. Disorientation within this tiny cavity during surgery carries immense stakes. A single millimeter of drift can result in catastrophic brain damage, permanent hearing loss, or a lethal hemorrhage. To safely navigate and memorize this space, clinical anatomists do not rely on raw 3D visualization. Instead, they use a highly specific, standardized architectural model. Mastering this simplified spatial map is the absolute prerequisite for avoiding lethal complications in otolaryngology. This diagram abstracts the tympanic cavity into a 6-walled box. Inside, it houses sound-conducting ossicles and nerve fibers. Outside, each incredibly thin bony boundary interfaces directly with critical cranial structures, offering almost minimal structural resistance to encroaching disease. The governing rule of the tympanic cavity is simple: topographical adjacency directly equals clinical vulnerability. Looking at the diagram's superior boundary, we find the tegmental wall. Formed by the tegmen tympani, this paper-thin plate of temporal bone is an extreme hazard. It's the only barrier separating the middle ear from the temporal lobe of the brain. Moving inferiorly, the jugular wall forms the floor. Immediately below this dangerously thin bony plate lies a massive vascular structure, the superior bulb of the internal jugular vein. The floor is also pierced by the tympanic branch of the glossopharyngeal nerve, traveling upward. The vertical axis of the middle ear is flanked by the central nervous system above and massive venous return below, leaving zero margin for upward or downward surgical errors. Shifting to the diagram's lateral boundary, we hit a wall defined primarily by the membranous eardrum rather than solid bone. To understand this unique anatomy, we have to trace its embryological origin back to the 4th week of fetal development. This developmental illustration maps out the collision zone. The growing endoderm of the first pharyngeal pouch expands outward, meeting the invaginating ectoderm of the first pharyngeal cleft. The tympanic membrane is the permanent, 3-layered result of this exact cellular collision. A direct physical consequence of this development is the malleus. Because it derives from the first pharyngeal arch, this bone develops permanently embedded within the membranous wall. The lateral wall acts as an embryological border town, functioning as the crucial mechanical transducer between the external world and the inner ear. Returning to the diagram, the opposing backside of the box forms the medial or labyrinthine wall. Its most prominent central feature is the promontory, a visible bulge created by the basal turn of the cochlea pushing laterally into the space. This wall contains the oval window above and the round window below. Above them sits the most dangerous surgical hazard, the bony canal housing the facial nerve. Just posterior-superior to this is another bulge, marking the lateral semicircular canal. The medial wall represents the ultimate hazard zone. A single millimeter of misplaced instrumentation here guarantees permanent hearing loss, severe vertigo, or unilateral facial paralysis. Looking at the anterior wall on the right side, the boundary is defined by its proximity to the carotid artery. Its primary functional feature is the auditory tube opening. This tube vents pressure into the nasopharynx, acting as an essential equalization valve. Moving to the opposing posterior wall brings us to the mastoid boundary. Superiorly sits the additus and antrum, linking the cavity directly to the mastoid air cells. Below it is the pyramidal eminence, a bony projection housing the stapedius muscle. The anterior-posterior axis dictates airflow throughout the cavity. It functions with an intake vent forward and a massive structural exhaust pathway backward. The layout of these 6 walls determines the specific pathways infectious diseases follow. Most middle ear infections originate in the throat. Pathogens travel upward, entering the box through the anterior wall's auditory tube. As the infection builds, unchecked pressure forces pus backward. It escapes through the additus, expanding the infection deep into the mastoid bone. Highly erosive infections pose a lethal superior threat. The pressure can breach the paper-thin tegmen tympani on the roof, entering the cranial vault. In the middle ear, an infection's physical path of least resistance directly dictates the resulting massive neurological catastrophe. This final view maps the 6 walls to their primary clinical risk factors. The roof threatens the brain, the floor risks the jugular, and the anterior wall sits against the carotid. Accurate anatomical mapping provides the data needed to predict clinical behavior. This six-walled box model provides a logical, predictable structure for navigating an otherwise chaotic bony cavern.